a Synoptic colon cancer pathology report everything surgery podcast. Deep dive into a real-world colon cancer case. Welcome to the Everything Surgery podcast, where we dissect extraordinary cases and bring you the latest in surgical pathology. Today, we present a detailed colon cancer pathology report, walking you through each section as it would appear in a clinical setting, but with the clarity and flow of a formal podcast narrative. Patient and specimen details. Let's begin with the patient's background. Our case features Jane Doe, whose medical journey started with a colonoscopic biopsy confirming cancer in the cecum. She underwent a laparoscopic procedure to remove a segment of her right colon. The specimen, received on October 26, measured 22 centimeters in length, with an attached mesentery extending up to 10 centimeters. Dr. Smith led the surgical team for this procedure. Clinical history and diagnosis. Jane's clinical history indicated a confirmed adenocarcinoma of the cecum. The preoperative diagnosis was colon cancer, and after surgery, pathology revealed an invasive adenocarcinoma in the cecum. This diagnosis set the stage for a comprehensive investigation into the extent and nature of the disease. Macroscopic findings. Upon gross examination, the right colon segment displayed a firm, irregular, and ulcerated mass within the cecum, situated 3 centimeters from the ileocecal valve. The mass measured approximately 4.2 by 3.8 by 1.5 centimeters. The serosal surface at the tumor site was puckered and retracted. Importantly, both the proximal and distal margins appeared free of tumor. Additionally, 12 pericolic lymph nodes were identified within the mesentery. Microscopic analysis. Under the microscope, the pathology confirmed a moderately differentiated adenocarcinoma. This means the cancer cells formed irregular and complex glands, showing some resemblance to normal colon cells but with notable abnormalities. The tumor had infiltrated through the muscular layer and extended into the surrounding fatty tissue, displaying a desmoplastic reaction in the supporting stroma. Lymphatic and blood vessel invasion was present, though there was no evidence of cancer spreading along nerves. Notably, cancer reached the serosal, or outermost, surface of the colon. Both surgical resection margins were clear of adenocarcinoma, suggesting a complete removal of the tumor. 12 lymph nodes were examined, and 4 of these contained metastatic cancer cells. This finding places the patient at a higher risk category for recurrence and guides the next steps in treatment. Pathologic staging. The tumor was classified as having invaded through the visceral peritoneum, which is the outer covering of the colon. The involvement of 4 out of 12 lymph nodes by metastatic adenocarcinoma places this cancer at the pathologic stage, classified as stage IIIC. The staging system used is the American Joint Committee on Cancer's 8th edition, which combines tumor size, depth of invasion, lymph node involvement, and, when known, the presence of distant metastasis. In this case, no information was available regarding distant spread, so further clinical and radiological correlation would be required. Additional biomarker studies. Further studies were conducted to evaluate the tumor's genetic and molecular profile. The mismatch repair system was found to be proficient, meaning the tumor cells retained normal expression of key repair proteins. This result suggests standard treatment protocols are appropriate. Mutation testing for genes such as CROS, NRAS, and BRAF was pending at the time of the report, which is essential for determining suitability for targeted therapies, especially in advanced cases. Synopsis and clinical implications. To summarize, Jane's case involves an invasive, moderately differentiated adenocarcinoma of the cecum, measuring 4.2 centimeters. The tumor extends through the muscular wall and into the fatty tissue, with involvement of the outer serosal surface. Lymphatic and blood vessel invasion is present, but there is no evidence of nerve involvement. Surgical margins are clear, and 4 out of 12 lymph nodes contain metastatic disease, placing her at a high-risk stage 3 category. The mismatch repair system is proficient, and further genetic testing is underway. This standardized report provides all the critical information needed for staging, prognosis, and treatment planning. Notably, stage 3 colon cancer with these features strongly supports the need for post-operative chemotherapy to reduce the risk of recurrence. The presence or absence of specific genetic mutations will guide additional targeted therapy options going forward. Explanation of key terms. Adenocarcinoma, a cancer arising from the glandular cells lining the colon, moderately differentiated. Tumor cells partly resemble normal colon cells, which influences prognosis. Margins. The edges of the removed tissue. Clear margins mean the tumor was fully excised. Lymphovascular invasion indicates cancer cells have entered blood or lymph vessels, increasing the risk of spread. Mismatch repair proficiency. Normal gene function for repairing DNA errors. Helps guide treatment. Pathologic stage. Combines tumor size, invasion, lymph node involvement, and distant spread to classify disease severity. Thank you for tuning into the Everything Surgery podcast. If you found this case insightful, please like, share, and subscribe for more deep dives into surgical pathology and clinical decision making. Stay informed and stay extraordinary.